Hello, everyone. Welcome back to the Hrithik Sangani Podcast. Here we interview professionals in medicine, health, and science and discuss innovations that can aid in human longevity. Today, my guest, he graduated from Rutgers University, his medical degree. He did his residency at the Mayo Clinic. He is an infectious disease specialist at UPMC Presbyterian, and he is a clinical associate professor at the UPMC Medical Center. Please welcome Dr. Neel Shah to the podcast. Dr. Shah, thank you so much for coming on.
Yeah, thanks for having me.
Awesome. You've been interviewed multiple times as part of the course for becoming a doctor, but I think is this your first podcast?
It is actually. Yeah, I've never done a podcast like this before. Yeah.
How you feeling?
It's good. So seems pretty cool so far. Very interesting.
Sounds good. So Dr. Shah, I think when people think about infectious disease, we're probably thinking of images like hazmat suits, biohazard signs, The Walking Dead. I watched World War Z not too long ago.
Yeah, movie.
Yeah, Brad Pitt with his dreamy hair.
Yeah.
But in all seriousness, is infectious disease always that serious, or are you guys are tackling some manageable conditions? Like how would you say the gravity of infectious disease is?
Yeah. So infections are a very broad spectrum of illnesses. And they could be mild. An infection could be as common as literally the common cold, which is a self-limiting illness, and you get better in a couple of days. It could be much more serious, where you get infections involving your brain or your heart, your lungs, your any organ can get infected. And so where the infection occurs and the host status of the person can determine the severity of the infection.
Okay.
So it's a huge variety.
Okay. Kind of diving into your why a little bit. Take me back to Dr. Shah when he was in medical school.
Yeah.
When did you realize that studying and treating infections was what you wanted to do to help people lead better lives?
Yeah. It was actually the last year of med school.
Last year?
Yeah, I didn't know until the very end, which is, it was down to the wire.
Yeah.
I did something called a sub-internship or an AI. They call it different things. Basically, as a med student, you have one rotation where you act as an intern. And during my AI rotation, I was on with a infectious disease doctor. He was the medicine attending that was overseeing us. And then for, I guess as fate would have it, all the admissions we got, or at least many of the admissions that we had, were infection related. And so we would see all this. I saw all sorts of great stuff. I saw TB. I saw a parasitic infection called neurocysticercosis during that time. I saw something called a perinephric abscess, which is an abscess around the kidney.
Oh, okay.
So I still remember the cases I saw. But the fact that there was, infections could involve any part of the body, and it can present in so many different ways. That challenge really intrigued me. I get bored easily, so I like the fact that I didn't. I guess the infections could occur at any part. I had to stay on my toes the whole time, and you always had to think about the patient, the infection, and the actual site of the infection,
Mm-hmm.
and the interplay between the three really appealed to me. I like, kind of thinking about all those things.
Yeah, when I was shadowing you, and I believe I made this comment where it's when I was observing how you were working through with your residents on how to tackle these infectious diseases, it was almost like it's like a detective issue, like problem, like you're solving through a puzzle with multiple different moving parts.
Yeah, that's exactly right. That's how I would think about it as well.
Yeah.
I mean, basically you're always thinking about like different variables affecting what's going on.
Yeah.
And I like that. I mean, some people don't like that. This is the kind of job that keeps you on your toes. You have to be aware of what's going on with the patient, what's going on with the infectious process itself. And then different variables can change how you manage the patient. So,
absolutely, yeah.
Yeah.
So, Dr. Shah, this podcast has a pretty diverse audience. So we have people who are in medicine, but you also have people who just want to understand the intricacies of science and medicine.
Sure.
So what I like to do on this podcast is I like to establish a common understanding of some complex terminology.
Sure.
So when in my work as a, I work as a patient care technician at UPMC Mercy, we talked about that.
Yeah.
I hear patients often use the words illness and disease interchangeably, and I see that it can affect their understanding of their condition. But words mean things, right? And these are these two distinct terms, so they have to mean different things, right?
I mean, they are similar, but there is a subtle difference between illness and disease. So
Yeah.
illness is more of a subjective term. So it's probably it's more of what the patient perceives their symptoms to be, whereas disease tends to be more of a objective abnormality.
Mm-hmm.
So it would combine the symptoms associated with an illness with objective data, like a biopsy result, a culture result, something to establish that the illness is due to an underlying pathology.
Okay, so illness is a subjective term. So when if a patient were to say, "I feel sick," that's they feel like I have an illness. Is that say that's accurate?
The symptoms could be representative of some sort of illness.
Illness.
But once they get evaluated by a medical professional and get testing done, if that testing confirms an underlying pathology or abnormality, then that illness would be characterized more as a disease.
Gotcha. And pathology would be how would you define pathology in this context?
Any abnormality, anything that shouldn't be there.
Okay. Okay. So like if we do a biopsy of a lesion and there's some bacteria in there that shouldn't be there.
Yeah.
Right. Then okay, we have a confirmation that we have something that shouldn't be there, and the patient's symptoms and how they're feeling, this all lines up.
Yeah.
Okay.
Exactly.
Okay. Now, diving deeper, you have the term infection and infectious disease. So like, let's say I scrape my knee, right? That wound could get infected, but is that an infectious disease?
Yeah. So an infection, well, the wound could, are you asking, well, let me clarify it from my end. So someone who gets injured and has in terms of infection, right? That is usually characterized by two things. It would be a combination of symptoms with positive culture data. So all infections produce an inflammatory response. If you get an infection in your lung, you're going to get inflammation in the lung. You're going to start coughing. You're going to start feeling short of breath. Coughing and short of breath on its own is not necessarily indicative of infection. But if you culture the sputum and it shows a bacteria that's pathogenic,
I see.
Now you have the combination of the organism and the symptoms.
Okay.
That creates an infection. Symptoms alone don't create or don't establish infection definitively. An organism alone doesn't necessarily always establish infection definitively. Certain bacteria can colonize various parts of your body, and that's normal. But when you have the combination of the symptom and the pathogenic organism, that creates an infection.
Okay. So if you have, it's like you have to have both of the symptoms lining up with the culture result to establish that there is an infectious disease.
Generally, that is the way we approach things.
Okay. Correct. Okay. Now, so now you have something like your run of the mill cold, and then you have something like Ebola. Like that's two very different ends of the spectrum in terms of severity of what you could get infected by. Is there a criteria that a condition must meet to be considered an infectious disease?
Yeah. Again, it's a combination of the symptoms that the patient presents with.
Okay.
With microbiological evidence, ideally. Sometimes you can't always get that. Some organisms don't grow as easily as others. But that can be supplemented by adjunctive workup testing. So things like imaging, blood work, they can help aid in the diagnosis of infection. So certain results can skew you towards a higher probability of someone being infected, even if the cultures don't necessarily grow something. And then there's certain tests that can be done to look for organisms that don't readily grow on standard cultures or in broth and things like that.
Okay. So then could something like your average cold grow to become severe enough that it's considered an infectious disease?
So yes, the answer to that is theoretically yes.
Theoretically.
So how severe an infection is also depends on the organism itself, but also the status of the individual. So people with relatively weakened immune systems or people who have structural disease in their body,
Mm-hmm.
that can predispose them to getting a more severe manifestation of infection. So I'll give you an example. Let's say I get the cold. For me, I may just simply get stuffy nose, a little bit of a cough, and maybe low-grade temperature,
Mm-hmm.
and I get better in a couple of days. But if someone has a compromised set of lungs, so from smoking or COPD, a respiratory viral infection could cause a much more significant manifestation of symptoms. They could look a lot worse. They could even get to the point where they're so sick that they need to be hospitalized.
Okay, so this isn't necessarily a clear cut answer. You have to factor in all these other factors, criteria, to then assess. Okay, is this something we can deal with pretty easily? Right, and there it's just like a very, I wouldn't say benign, but I would say a low grade or it easily dealt with infection versus it balloons up to something worse.
Yeah, so there's a lot of factors that come into play when you're determining how severe an infection could become in someone.
Okay.
So the organism itself can play a huge role. I mean, there's, like you mentioned before, the cold, the virus that causes the cold generally doesn't release a lot of virulence factors, and it's not as aggressive as something like Ebola.
Okay.
So that virus is much more aggressive when it infects humans.
Okay.
And like I mentioned before, the status of the host, the patient, can
also
play a big role in how severe an infection can develop in that individual.
Gotcha. So between me and someone that's say 80, right? Like if I catch the cold, chances are I might recover in about a couple of days or so because relatively young, my immune system is younger, right?
Yeah.
But someone who's 80 who might have a compromised, like you say, let's say they smoke, right? They have a compromised pulmonary system.
Yeah.
Or, a lot of these other things that I'm sure we will dive into, then the flu for them
could be much more severe.
Yeah. Now, if both me and the 80-year-old in this scenario caught Ebola, it's not good for either of us.
Because the organism is so much more aggressive.
Okay.
Exactly.
Gotcha. Okay.
Right.
Okay.
Yeah.
Cool. So, Dr. Shah, the theme of this podcast is, we discuss innovations that can aid with human longevity. And when I say longevity, I don't just mean the length of our lives, but it's the quality of those lives of those years are also good. So it's like our health span.
Yeah.
So when we're talking about infectious diseases, I think that if we can do our best to prevent, or at the very least avoid these conditions, our quality of life will increase. So, Dr. Shah, as we get older, how do you think we should be looking at or approaching infectious diseases? How do we prevent them as we get older?
Yeah, I mean, the big thing is, so as you age, your immune system is not as robust as it was when it's younger. There's a process called immunosenescence that develops over time. So what that means is that the quantity of immune cells that are produced actually decrease over time.
Okay.
And then the distribution of the types of immune cells that are in your body can change as you age as well. And that can set you up for a higher risk of infection potentially.
Mm-hmm.
In addition to that, as you age, the natural barriers to your body become weakened. So your skin tends to get thinner, your mucous membranes become less robust, and you're more likely to transmit something through those barriers that were once much more protected, I guess.
Yeah.
In addition, as people get older, they tend to get chronic medical conditions, and those things can also influence their risk for infection. So if you have diabetes for 10 days, it's not the end of the world necessarily. But if you have diabetes for 10, 20, 30, 40 years, that disease process can damage the immune system over time.
Mm-hmm.
So that all being said, there's two aspects that you should keep in mind when you're looking out for infections as you age. One is the preventative aspect.
Mhm.
So that includes getting your vaccinations. It also includes minimizing any unnecessary risk factors that don't put for example, you know,
I think we looked at smoking was one,
yeah.
right? Smoking was
So
one.
using illicit substances, smoking, um, controlling your pre-existing medical diseases. These are all things that you can do to help reduce your infection risk in the long run.
Actually, when I shadowed you, we had a couple of patients that had they took illicit substances.
Yeah.
And that by the mechanism of how that illicit substance interacted with their body, it created the grounds for an infection. And these people were actually they were in my age demographic, some of them.
Yeah. Unfortunately.
Could you explain kind of how that kind of turned, some of those cases? So you saw that.
Yeah, I mean, with regards to substance use, unfortunately, that's a prevalent problem across the country. The mechanism by which they introduce drugs into their body, so through injection or snorting, these things can break the natural protective barriers of the body and then increase the risk of infection. When you inject something into your skin, the skin is your largest organ and the biggest protector of your body from the outside environment. So once you inject or cut or injure that area that you're introducing the drugs into, that allows a portal of entry for bacteria, fungi, and viruses, all sorts of stuff to get into the bloodstream. And that can increase your risk of infection.
Absolutely. So kids, don't do drugs. Remember the dare line. Don't do it. But focusing on the preventative side for a minute and the process as you're getting older. So a question I have for you is, if you get infected, is a chronic infection that you get as you age, can that accelerate the aging process itself?
Like having getting repeated infections, do you mean? Or do you mean like...
Well, okay, then let's distinguish the two. So you have one infection that lasts for a while.
Sure.
Or you get one infection, you get over it, but then you repeatedly get it. That sounds like there's two different cases, though.
Yeah, that would be two different things. So people who get repeated infections over and over again, that would raise concerns for an underlying immune problem, or it could suggest that you are predisposing yourself to infection for a number of reasons. Like I said, someone who smokes, someone who injects drugs, someone who carries some sort of high-risk behavior.
Okay.
Or someone who has like an intrinsic medical issue, like I said, COPD is a common example where when you have ongoing structural lung disease, you're going to be at risk for infection over and over again. Unfortunately, that's just one example. There's plenty I can list, but that would be that's one type of chronic infection. I guess that would be more of a just repeated issue over and over.
Right.
And then there's certain infection processes that are ongoing in nature. They can't be controlled with standard treatment. So that's along the lines of what I do. I'll give you an example. So prosthetic joint infections, these are infections that are associated with metal that's put into your body to stabilize a joint. If that metal becomes infected and the surgeon can't remove the metal, then that infectious process is very difficult to cure with antibiotics alone, because the bacteria that can form this biofilm, a film of infection, which sticks onto the metal, and then that's difficult to eradicate with just antibiotics. So those people need to be suppressed with antibiotics to prevent that biofilm from flaring up and causing more severe illness.
Gotcha. Okay. So it sounds like if you're getting repeated infections, that might be an issue where we have to look at, okay, what else is this person doing? Do they have an underlying, would you say an underlying chronic disease? That's one thing.
Yeah. It could either be an underlying medical condition, it could be an immune problem, immune deficiency syndrome, or it could be something they're doing in their day-to-day lives that's setting them up for an increased risk for infection.
So some of the patients we saw, they were using illicit substances, stuff like that, right?
Yeah.
And then you have a patient that has a infection last for a while. So in your instance, with your research area, which we'll definitely dive into more later, with the prosthetic joint infections.
Sure.
Also, would you say HIV might also be something like that, where you have this immunodeficiency caused by this virus for a long time?
Yeah. So HIV is unique in the way that it is a virus that can cause infection, and by its own nature, it can weaken your immune system to increase the risk for other infections.
So it's a double whammy.
Yeah, so that would be a double whammy kind of scenario. Absolutely.
So this begs an interesting question: is if you get cumulative infections, whether it's so it would be the repeated ones, like you get infection after infection.
Yeah.
Does that decrease your immune system's capacity over time to fight off every successive infection?
It depends. Again, generally your immune system can take multiple hits, meaning that if you get infection after infection, your immune system will ramp up. It'll try to fight the infectious process that's occurring.
Okay.
Again, if those repeated infections are occurring due to a weakened immune system, then that's a different issue entirely. But again, if you have a normal immune system and you keep getting repeated infections, um, you know, generally the immune system would be ready to fight that infection off. There is newer studies coming out that ongoing like activation of your immune system over a long period of time can create this chronic inflammatory state.
Okay.
And that can trigger that immunosenescence phenomenon more faster. So meaning if you keep getting infections over and over again, it creates a chronic level of inflammation in the body. And and then basically, that in turn can weaken the immune system by dampening that effect over time.
Do you mind actually, real quick, explaining this chronic inflammation and immunosenescence dynamic? Because I've in longevity medicine, or among people like to say they're longevity doctors, they talk about this chronic inflammation and how it actually can accelerate. That can also accelerate the aging process of the body. So, in the context of infectious disease, what role does chronic inflammation play with like the immune systems and its immunosenescence that you talked about?
Yeah, so all infections cause inflammation.
All of them. Okay.
Basically, yeah, because an infection creates an inflammatory response within the body. That's why you get the fevers and chills and the symptoms that people develop.
Raising your blood, your temperature in your body, and it's also shuttling the things needed to fight the infection to the site.
Yeah,
okay,
exactly. So, that chronic inflammatory, if you get a chronic inflammatory state due to a chronic infectious process, it's the state, the effects are the same as any other chronic inflammatory state, and so that chronic inflammation can cause a blunting of the immune system response over time, which can dampen the effects of that immune response as you get older. And again, like I mentioned before, as you get older, a number of things change. You produce less antibodies, you produce less immune cells, and then the distribution of the immune cells that are present in your body can change as you age.
Okay.
And then those factors can also play a role in increasing your risk for future infections and even increasing the risk for a more severe infection potentially.
Okay. So can chronic conditions like, say, diabetes, cancer, can it create an environment where your body is perpetually inflamed, and then that also can prime the body for an infection?
It can, yeah.
Okay.
Diabetes and cancer have also other mechanisms by which they can increase infection as well, besides the inflammatory state. But like, for example, diabetes, if it's chronic enough, it can damage the blood vessels in your body.
Okay.
Those blood vessels are the highways for your immune system to get to an area of infection. So if those blood vessels are damaged or destroyed, the immune system, even if it's robust, is unable to get to the site of an infection. That's why diabetics often get infected ulcers and wounds and things that develop. With cancer, the cancer can cause an increased risk for infection in a number of ways. One is through that chronic inflammatory process. Another is through the invasion of the cancer through healthy tissue. As it damages that tissue, it can actually create abscesses and pockets of infection, which can create problems for the person. And then the treatment for cancer weakens the immune system. So chemotherapy and immunotherapy and things like that can reduce the activity of the immune system, which can increase your risk of infection as well.
Yeah, I'll share a quick patient story. So one patient I was taking care of, he was diabetic, and it's typically when you see diabetics that have like infections, it's usually in the feet.
Yeah.
But in this case, this patient had it in his fingers.
Sure.
He had no fingers.
Okay.
It was pretty horrific actually to see for this guy. But he also had an infectious disease. He had COVID actually. That was So he had COVID, and then he had a chronic issue. He had a chronic disease of diabetes that now he couldn't eat because he couldn't pick up a spoon. So it was a pretty severe just overall condition that this patient had. So would that be an example of like where you have a diabetic patient, and then that's kind of creating the breeding grounds for a disease like COVID?
Yeah, so uncontrolled diabetes, like I mentioned before, can damage the blood vessels in the body, and those blood vessels are the highway for your immune system to get to where an infection or an area of injury is. If the immune system is unable to do that, wounds can fester, they can become infected over time. So these things can accumulate over time and compound on each other. So if you have diabetes and then you develop an infection and you have blood vessel issues, it could be a recipe for a lot of complications potentially.
We talked about immunosenescence. Is that how do you define immunosenescence? Actually?
Yeah, it's in the simplest terms, it's just aging of the immune system over time.
Why does the immune system age?
Yeah, so everything in our body ages over time. So it's mostly there's changes on the cellular level. There's changes. Again, when people have chronic illnesses or disease, these things can compound and create more problems over time that affects the immune system. And so it's a combination of your body's natural process of aging, which affects all cells in your body, including your immune cells, but also a person's medical background and their history and what they've exposed themselves to, which can also contribute to that loss of immune function.
You said something really interesting. You said the actual distribution of your immune cells also decreases. So not only are your immune cells not working as well, you also have less of them as you age.
Yeah,
is that right?
And you also change the type of. There's different immune cells in your body, and then that distribution. Certain immune cells decrease in quantity, and certain can change and increase in quantity. But that shift in the changes in the type of the immune cells can also contribute to the aging of the immune system and increase the risk of infection in theory.
So I did cancer research, and one of the projects that we were working on was an mRNA CAR T for acute acute lymphoblastic leukemia.
Okay.
And it was just targeting like the B cells. Sorry guys, I'm getting a little nerdy, but the targeting B cell cancerous B cells essentially.
Sure.
So I'm curious, do you have less like white blood cells basically, or like you have less different kinds of white blood cells? How do you?
Yeah. So there's different. So when we talk about the immune system, it is much more complicated than just saying it's one system of cells.
Of course,
there are multiple different types of immune cells, and these immune cells do various things within your body. They target different types of infections, different types of abnormalities in the body. Your immune cells are responsible for fighting infection. They eliminate tumor cells. They clean up damaged cells within your body. Like I said, each cell has a different role within the immune system. And so any change or shift in those cell types can vastly affect how your body responds to different things, including infection.
So I kind of want to go into a little bit about, like, I actually forgot to cover this in the beginning, but so like when you were looking at treatments for a lot of these infectious diseases, so you said something really cool when I was shadowing you, and you asked this of one of your residents. You said every medical specialty has its own language.
Sure.
So you said to your resident, the language of oncology, that's study of cancer, is chemotherapy, drugs. It's about understanding the stages of cancer.
Yeah.
What would you say the language of infectious diseases?
Yeah. It's probably three things. One is the understanding of the different organisms that can infect your body.
Right.
So if you don't know the organisms, you're not going to be able to understand how to treat them. The second part is actually the treatment itself. So understanding the medications that are used to treat these organisms when there's an infection that's established. Because without knowing the various treatments, it becomes very difficult to form a plan and how to treat and address the patient. And then the third part is actually the mutations that are associated with the different organisms. because that influences the treatment. So understanding those different mutations and abnormalities that the organism can possess will influence the treatment. So the interplay between the three things is really where the language of infectious disease is.
So when we're looking at the antibiotics,
Yeah.
actually, this might sound like a basic question, but I think it's still important for people to understand the difference between an antibiotic and an antiviral. Obviously, what they target, yes,
Sure.
bacteria versus virus, but just kind of how are they attacking that thing, that condition?
Yeah, I mean, so antibacterial medications, which are antibiotics, they target bacteria, but they can do it in multiple different ways. They can affect how a bacteria produces various proteins that are essential to its survival. They can affect how so the bacteria has a cell wall, which kind of like our skin protects the bacteria from the outside environment.
Mm-hmm.
So certain antibiotics will destroy or prevent that cell wall from forming properly, which can in turn destroy the bacteria. It can affect the DNA of the bacteria, and so it can't replicate and propagate like it normally would. And antivirals, again, although they only target viruses, they are doing similar things. They're not, I mean, again, bacteria and viruses have structurally different components to them, but they both need to replicate, they both need to propagate, they both need to find ways to continue to exist.
Basically. Yeah.
So affecting those things are basically the mechanisms which affect those things are what drugs do to target those various
So
infections.
they're targeting the bacteria and the virus's respective ways of producing more of themselves, right?
Yeah.
I know there's different kinds of viruses that can reproduce differently. There's one that there's if I remember from my biology class, there were two kinds. So there's one that I like to understand it as the alien type of virus, the lytic virus. So it goes in, it uses your body's machinery and your cell's machinery. I'm sorry.
Lysogenic is the other one.
And lysogenic is the one. That one actually seems a little bit more insidious, where it actually incorporates itself into the genetic code of your cell, and so your cell will actually just produce the stuff to make the virus. So
So for antivirals and antibiotics, again, the trick for both of them, they target different things, like you mentioned. Antibiotics only target bacteria, antivirals only target viruses. But as each class as a whole, their goal is to specifically interfere with or prevent various processes within the virus or bacterial life cycle from occurring to prevent the growth and propagation of those organisms.
Mm-hmm. Well, looping this back into the longevity discussion. So as patients age, and you have a patient in front of you that's say they're in their 20s, 30s, 40s, 50s, how do you factor in the age to and whatever infectious disease they have to what kind of antibiotic or antiviral you give to them? Is it if they're younger, you can probably give them a more severe antibiotic or antiviral, they can take the side effects of it. How do you guys like to look at that?
Yeah, so it's not really based on that. What we try to do is, once we identify an organism, we try to, first thing we always look at is what's the most effective medication for that organism, because we want to make sure our priority is always to eliminate the organism, get rid of the infection.
Okay.
If there are multiple options, the next thing we usually look at is which one is going to produce the least amount of side effects. And this is difficult to determine definitively. Different patients respond to different antibiotics in different ways. But there are certain antibiotics that have a higher number of potential side effects, and some have less. And so picking the optimal drug with the least amount of side effects is usually the goal when we try to treat patients. So yeah, that's basically what we look for.
Okay. Because antibiotics and antivirals, they have their own side effects that have to be managed.
Yeah.
What are common side effects of antibiotics and antivirals?
Yeah. So almost any medication you put in your body can cause some universal side effects. So GI related, gastrointestinal related side effects like nausea, vomiting, diarrhea can occur with almost any antibiotic or antiviral in theory. Doesn't mean it has to happen, but it can happen. Um, Depending on the person, you can get an allergic reaction to a medication. That could be something as mild as a little rash or some itchiness, to something called hives, where you get a diffuse rash that's throughout your body, or anaphylaxis, which includes having hives combined with breathing difficulties and facial and lip swelling and
Oh,
things
geez.
like that.
Okay.
So there's a very huge spectrum of how an allergic reaction can present in one individual compared to another. Um, and then, antibiotics can theoretically cause issues with your kidney, liver, bone marrow, but these things are monitored. And again, these are relatively low risk. Um, but yeah, I mean, those are like kind of the things that that we look out for.
Okay.
So,
So, but you guys, so first order of business though is eradicating the infection.
yeah.
So not to say that age doesn't play a factor into your guys' treatment, like your treatment plan, but it's I don't know, how would you describe it? Like
Yeah.
if it's more severe, you're like, all right, listen, like is it like you have to break an egg to make some omelet kind of thing, where it's like, listen, they're gonna have some side effects. It's probably really going to be really severe, but it gets the infection out of the way.
Yeah, I think the way that age would play a role in antibiotic or antimicrobial selection is that when people age, they are more likely to have chronic medical issues. And those chronic medical issues could influence the medication that's given. For example, if someone has chronic kidney problems
Okay.
after, from high blood pressure or smoking or diabetes or something like that, there are certain medications that we would give that have a higher risk of causing kidney damage. And so we may want to avoid giving those patients that medication in favor for another medication that's less likely to cause kidney damage, as long as the efficacy is comparable.
Okay. How do you guys select? So when you guys have an infectious disease, like, so let's say it's a bacteria, you analyze what the bacteria is. Let's say it's staph, if like staphylococcus, right?
Okay.
How do you guys go about testing which antibiotic will be the most effective? Do you just kind of know, like, oh, we know this antibiotic is most effective for staph, and then you try it, or do you culture it, you test the antibiotics, and then whatever's the best at eradicating it, that's the one you give to the patient?
So usually it's the latter.
Okay.
So what we do is when we identify an organism, our microbiology lab does a susceptibility panel, which can help guide us to find the optimal antibiotics that could be used for the patient for that infection.
Mm-hmm.
And once we have that information, then we start incorporating, like you mentioned before, the patient's comorbid conditions, their age, the side effect profile of the medications that are available for treatment, and we use that information to decide what's the best treatment for the patient.
Right, because you don't want to just throw darts at the wall and kind of just see what happens, because that could probably lead to like, antibiotic resistances, right? Like that's something I guess you guys want to be careful of.
In medicine, you don't want to throw too many darts at the wall.
No, definitely let's not do that. But speaking of chronic, and also looping this back into the chronic disease discussion, have you ever found that a infection can lead to or trigger a chronic condition?
Yeah, that can happen, believe it or
Really?
not. So, like I said, whenever someone develops an infection, there is an inflammatory response associated with that. There is an activation of the immune system. Through multiple mechanisms, which we don't have to talk about here, but there are ways that the infection can trigger an abnormal immune response, which can cause all sorts of weird manifestations, autoimmune disorders. It can trigger neurological issues. It can trigger like a wide variety of things, and I can go through examples if you want. But
yeah, can you give like one or two examples?
Yeah, sure. So there's a bacteria called Campylobacter, which causes diarrhea.
Oof.
It's usually higher risk when you're exposed to eggs and avian products, and it can also be seen commonly in travel. Normally, that bacteria causes a diarrheal illness, which is treated with the antibiotics. But in a certain proportion of people, due to a dysregulated or hyperactive immune response that's triggered by the bacteria, you can get a neurological process called Guillain-Barré syndrome. So you can get it's basically a demyelination disorder, which can cause weakness in your legs, and it basically causes ascending
Gotcha.
paralysis.
That's the myelin is for, I guess, for my audience. Myelin is the material that often covers neurons.
Yeah, it's
right.
the sheath that's around neurons, which allow for signals to propagate.
Right? It's my dad was a neuroscience major in Pitt.
Okay.
So the way he explained it is that the myelin can sometimes act as like a bullet train, so that gets that signal propagate faster if your neuron's covered in it. So what this this condition is, it's demyelination of your neurons caused by this. It's a bacteria? No, it's a virus.
No, it's a bacteria.
It's a bacteria.
So this bacteria can produce an immune reaction, which can, interestingly enough, cause damage to those myelin sheaths, which prevents nerve signals from conducting. So you lose that speed train that you were talking about, that bullet train process, and then that can cause ascending paralysis.
That sounds terrifying.
Yeah, I mean, again, this isn't common, but these can happen.
Right.
There's another bacteria called mycoplasma, which can infect the lungs.
Okay.
And that can cause a whole bunch of abnormal things. You can get something called autoimmune hemolytic anemia, where your body starts destroying your own red cells and can cause something called hemolysis, and results in like low blood counts. And it can also cause neurological manifestations as well. Again, this doesn't happen to every person,
right?
But these are things that have been documented in the literature. So it has been known to happen.
Yeah. I have seen in my experience patients that will come in with dementia-like symptoms.
Yeah.
And initially I think it's because, like, I would ask the nurses, oh, we were stroke force. Like, oh, did they have a stroke?
Yeah.
Or did they fall and like they hit their head? And sometimes it's like, no, they got an infection. I was like, an infection can do that?
Yeah. Yeah. So there's certain viruses that can trigger dementia, or, for example, HIV can do that. That's a well-known phenomenon of HIV. Over long periods of time, HIV can induce a dementia-like status. So it's literally called HIV-associated dementia.
Wow.
Yeah.
Okay. That's crazy.
Yeah.
Now, is it always a two-way street? I think we've talked about, so it's infections can trigger chronic diseases. We also talked about how chronic diseases can create the breeding ground for infections as well. So it's not always a two-way street. In your practice, what are you often more seeing?
It's actually a mix of both. It's more common usually for someone to have chronic medical conditions which can trigger infection.
Okay.
Like I said, these for infection to trigger chronic medical illnesses, it is possible, but it's not as common, I would feel like, as the former.
Yeah, the reason why I asked is because you can kind of think about this in two ways. You have patients who are people who are thinking about, okay, as I age, how do I avoid the chronic diseases? How do I avoid the infectious diseases?
Yeah.
And then you also have people who they're all old. They are old. They're in that age demographic, so they may have a chronic disease.
Yeah.
So, like, what can I do to avoid the likelihood, decrease the likelihood of the infectious disease development?
So a couple of things. I mean, if you have a pre-existing medical condition that can increase your risk of infection, optimizing your that medical condition, making sure that you're controlling your diabetes, you're controlling your COPD, if you have issues with your blood flow, optimizing your blood flow. These things would be very important in reducing your risk of infection long term.
Mm-hmm.
As you age, like I said, because of the way your immune system changes over time, you could be at increased risk for certain types of infection. You can minimize those risks by getting, age-appropriate vaccinations. Your shingles vaccine, your flu vaccine, your COVID vaccine. These things can reduce the risk of you acquiring those infections later on in life if you take them regularly. And that could reduce a potentially a severe manifestation of that infection, which could lead you into the hospital or the ICU.
Yeah.
And then your basic, standard recommendations for everyone, getting enough sleep, eating right, exercising, avoiding bad habits like excessive drinking, smoking, drug use of any type. These things are going to optimize your immune system, making sure that your nutrition is optimized, so that you have the necessary building blocks for creating a healthy immune system.
Actually, can we dive into that a little bit? So those are like the
Sure.
3 pillars of like longevity, I guess you could say. Actually, if you think about it, there are the 4. So it's diet, sleep, exercise, and I guess stress management would be the 4th one. Now,
Sure.
maybe for stress management, depending upon your job, that's a little bit variable. But like we can go into like some sleep, diet, and exercise. So not necessarily asking you to give like dietary recommendations, but like what is it about a healthy diet? Like what are those building blocks that come from a healthy diet that help your immune system fight off infections? Do you know it?
Yeah. So I mean, the things that you put in your body can either create an inflammatory state, or it can help
Reduce it.
inflammatory state. So incorporating foods that reduce that chronic inflammatory state that your body's susceptible to, that would be defined as a healthier diet.
Okay.
So processed foods and fatty foods and certain things are more likely to induce a chronic inflammatory reaction, damage your blood vessels and things like that over time. So restricting those things would be beneficial. And then there's certain other foods that actually can reverse that inflammatory state. And then those foods would be considered more desirable.
Okay. So I interviewed and his name's Andrew Wade. He's a dietitian. He's the CEO of Case Specific Nutrition.
Okay.
And we talked about how I asked him, hey, like why do we recommend like omega-3 like fatty acids as a dietary supplement?
Yeah.
And he talked about that's actually the form of the like saturated fat that is the anti-inflammatory version. And he said the omega-6 is the inflammatory one. He's like, now it's not necessarily that you should eliminate omega-6s from your diet, but he's like, from a dietary context, it's just that we eat too much food that's high in omega-6s or just these other substances that can create this inflammatory state.
Sure. Yeah. I mean, the proportion of what you consume in your diet plays a big role in whether you're in an inflammatory state or a non-inflammatory state from that end. Yeah.
What about like sleep? So I had to do extensive research for this podcast because I wanted to be able to talk to you about like as thoroughly. Now I'm by no means an infectious disease expert necessarily, but I just had to do my homework. But I read that sleep, like getting adequate sleep, helps your immune system. Like this is the terminology. You said increased immune surveillance. What does that mean?
Yeah, the exact benefits. So we know that sleep is beneficial, but the exact mechanism by how sleep produces its benefit, it's not as clear. So there seems to be some sort of restorative quality to sleep, both from a cellular level, but also because again the immune system is made from cells, from an immunological level.
Mm-hmm.
So there seems to be some sort of reparative or restorative effect that occurs while you sleep, which helps repair and restore your immune system in turn as well.
Okay.
But yeah, I mean, it's still not as clearly elucidated as some other things, but there definitely seems to be a beneficial effect in getting that adequate amount of sleep.
And then I guess exercise. So like from an infectious disease context, like how does adequate exercise decrease the likelihood of acquiring one of these infections?
Yeah, I mean, exercise can help in a number of ways. So one, when you exercise, you're ramping up your cardiovascular system, you're improving your blood flow. Again, like I mentioned before, the blood flow is the highway to the immune system to get to an area that's infected or damaged. So optimizing that blood flow, optimizing your body's ability to move that blood around is going to be important in helping to fight infections in theory.
Mm-hmm.
Exercise also can release certain chemicals in the body, which can actually help ramp up the immune system when there's need for it to be activated.
Does it help that ramping up process like happen easier? Like would you say like?
I think it helps it to I guess I mean, it'd be an immunologist could tell you that a little bit better than I can. But yeah, it definitely seems to help make it easier for the immune system to respond appropriately to whatever is going on in the body that's not normal.
Fantastic, because thinking about like longevity preventive medicine, it's like, okay, like how do we keep our immune, like we're gonna age, that's inevitable, but how do we keep our immune systems younger for as long as we can, like younger, like you stave off that immunosenescence.
Yeah.
Would you say that it's a combination of all these things you just talked about?
Yeah.
What other things can we do, or at least we kind of covered them all?
I mean, those are like the main things. I think adequate nutrition, the proper nutrition are going to be important. You want to make sure that you have enough of the vitamins and minerals that are recommended because they contain antioxidant properties, which are useful in fighting off abnormalities in the body, including infection, but also other things like even cancer and stuff like that. Maintaining adequate exercises, avoiding anything that could be detrimental to the body, like I mentioned before, like smoking and substance use and excess of alcohol and things like that. Getting adequate sleep for the reasons we just mentioned. All these things are going to play a big role in optimizing your immune system to help fight off infections and reduce the risk of any infections from even occurring.
Fantastic. Does infectious disease have any interventions aside from antivirals and antibiotics that help preserve a patient's function and health span?
Vaccinations.
Vaccinations. Okay, there you go.
That would be the other, like I said, getting the recommended vaccinations would play a huge role in preventing serious complications from these, from these viruses and even certain bacteria from creating problems in one's life over time.
And just to quickly, just for like some understanding, right? Like the way vaccinations do that is, I understand they're just introducing either a dead or like a very weakened strain of whatever virus it is, right? Like, and then how does your body take that? It's like analyzes it and it's like, oh, like, okay, this is what we are going to deal with in the future.
Yeah. So, I'll simplify it because it is complicated. But basically, every infection, every organism or virus, bacteria, whatever, has certain components to it that trigger the immune system. The immune system recognizes something that's abnormal by detecting various proteins and other substances on a bacteria or virus, which it deems abnormal. So if you introduce a weakened state of that organism, or you take a selective part of that organism that the immune system can recognize as abnormal, you can create an immune response that the immune system would remember. Again, the immune system isn't only retroactive, meaning it doesn't respond only just to infection and say, oh, I need to do something, but it is also proactive. It actually takes what it's remembered from an infection and creates cells called memory cells, which can become activated should you get introduced to that organism again. The purpose of a vaccine is to stimulate that proactive process, create these memory cells by introducing a specific virus or bacteria or component of that the immune system recognizes as abnormal. And once those memory cells are created, if you get the actual infection in the future, the immune system can tackle it before you get any clinical symptoms. It basically is already on top of things even before that organism has enough time to replicate or grow.
Gotcha. But then how long does that effect last for? Because boosters exist, right? So like vaccination boosters. So like typically how long does that last for?
Yeah, it's variable. I can't say there's no one standard answer to that, which is why different boosters are needed for different vaccines, basically.
Gotcha. Hey, listen, I always say that you're dealing with an expert when the answer is like, it's never like a cut straightforward. It's like, listen, it depends, because it depends on all these other different things.
Yeah.
Well, so we kind of went over like a lot of the preventative factors preventative actions we can take to avoid infectious diseases. But we also, both you and I, deal with patients that for one reason or another, they either didn't take those actions or maybe they did, but they have an infection.
Sure.
And they're in the hospital.
Yeah.
So, and my question to you is, is the fact that they're so sick, is that because of the infection itself, or is it because of the intangibles that just come with being in a hospital?
Yeah, I mean, it's usually a person is sick because of the organism that's present and how aggressive it can get, and combined with the patient's own body and what the state of that body is in.
Okay.
So like I mentioned before, if their immune system is weakened, if they have structural issues with their body, they're higher risk of developing a more severe infection. And then the organism itself could also create a rip-roaring immune response, and certain organisms don't do that. So those two things are the main factors. people who are hospitalized for long periods of time, they are in theory at risk for acquiring other complications as a result of that hospitalization. They're also tend to be more what we call deconditioned over time.
What does that mean?
So, we take this for granted, but, on a day-to-day basis, we all move around. We keep our muscles and our bones and
Yeah.
joints active just by the normal action of moving and staying mobile, going from place to place.
Yeah.
People who are hospitalized are usually bedbound for prolonged periods of time.
Mm-hmm.
That can actually weaken the muscles, the joints,
Weakening the skin.
and the skin.
Because you can get pressure. This is something that I learned working in the hospital. If you sit on those beds for too long, you can get pressure injuries. Have you seen that with your patients?
Oh, very commonly, yes.
Can you explain that a little bit? Like, because that's also an infection route.
Yeah. So, and again, this is something that we all take for granted because when you're feeling well, you can identify this pretty easily. But if you could even try this experiment, you try to sit in a position for more than 5 minutes without making a single movement, it's going to be uncomfortable.
Yep.
The reason it's uncomfortable is the pressure that's put on your skin, on your bottom and your legs. It starts creating a sensation of pain and discomfort, which forces you to move left and right.
Right.
When you're critically ill, when your mental status is not completely normal because of the infection or the illness that you have, you lose that sense to move.
The sensation to move.
Yeah.
Yeah.
So what happens is over time, that pressure that's put on your skin can devitalize the skin, cause it to open up. It's called a pressure sore.
Yeah.
Or in medical terms, it can also be called a decubitus ulcer. But
Decubitus.
yeah.
Right. Okay.
It just means an ulcer that forms along the surface of where a bone is. And that's where the skin is more likely to break down.
Is that because it's also it's the bed that's pushing up against the skin, and it's also the bone underneath that's like pushing down, and then it's over time is weakening the skin.
Yeah, you're sandwiching the skin between the bed and a hard surface, which in this case would be bone.
Yeah, I've seen them, like, not we sounding gross, but I see some pressure injuries that you could fit your hand through. It's pretty bad.
It can be pretty dramatic.
Yeah,
absolutely.
So like, I mean, and what we have to do as like what we're trained to do as patient care technicians is like you get this like barrier cream that you have to put around. I don't know how, I don't honestly know how effective that is. Like, I don't think it's going to stop it. Like, but it's just like to prevent any further damage or something like that.
Actually, it can be pretty effective.
Oh, okay.
It's used to do a couple of things. It prevents. It reduces the risk of outside things entering in through the skin, through that compromised area, which is why it's literally called barrier cream. It's creating a barrier from the outside environment to the inside of your body.
Mm-hmm.
But certain barrier creams can also be used to promote healing. So it can help heal the wound over time when used properly.
Yeah, I think there's a couple ones. There's ones that we use when the skin hasn't broken, but you can clearly see like if we don't do something, it's gonna break.
Yeah,
it's like a thicker barrier cream. There's ones that actually you have to put on open wounds, and that stops anything going in there.
Yeah, I mean the single most important thing to do for those patients is actually make sure they keep moving.
Repositioning, yes.
Yeah, so they reposition the patient to prevent that sandwiching effect we just talked about.
Yeah.
But that combined with the various creams that they use can help heal these wounds over time. So yeah, I mean,
so just being in it's not the fact that it's like, oh my God, being in a hospital bed is gonna like kill me necessarily. That's not what we're saying, but that's just something we don't think about. Like you said, we take this for granted. What our ability to move does for us.
Yeah.
And when you're in that position for long periods of time, that's I guess would you say that's an intangible that we actually don't consider about when thinking about infectious diseases. What other things about a hospital environment that people don't often think about that can contribute to an infectious disease?
I mean, again, hospitals are places where multiple people come when they're ill. So many of them are bringing in various types of infections that you don't necessarily have, but you can get. So one of the risks of being in a hospital for a prolonged period of time is acquiring infections that are present in other people. Again, the hospital, the doctors, we do everything we can to minimize that risk. There's various precautions that are taken.
Sanitation protocols, right?
Yeah. Exactly. But there is always going to be a little bit of a higher risk in those types of environments because a hospital is a place where sick people go to. And even the treatment sometimes, so antibiotics that we give people, Ironically, some antibiotics can sometimes increase the risk of a particular type of infection called C. difficile. So
Oh, yes. I'm very familiar with this one because I've had to treat a couple patients with C. diff. Can you explain what C. diff is?
yeah, so C. difficile is the name of a bacteria that naturally exists in your gut. When you take antibiotics, the antibiotics actually can kill sometimes normal bacteria in your gut. C. difficile, though, has the ability to hide from from standard antibiotics by forming what's called a spore.
An endospore or a spore?
Kind of like that. Yeah,
Okay.
it's basically it's an inactive state of the bacteria. And so what it can do is when times are rough, C. difficile can convert into the spore form, avoid being destroyed by the bacteria because it's not doing the activities that a normal bacteria would do, which the antibiotic would target.
Okay.
And then when the times get better, when the antibiotic exposure is gone, or when the environment of the gut changes, it can proliferate again and go back into its active state.
So like in a sense, it hibernates.
Yeah,
In a sense, right? Like that's what it's doing.
Yeah.
So, because this is something that they talk about in longevity is like the gut microbiome and how it has a role to play in chronic diseases and stuff. So I guess that's like something. Is that something you guys have to factor in it to some degree, like with when you're using antibiotics? Because if that's the case, like if you, like you said, you use the antibiotic and it changes the gut microbiome, it maybe leaves a vacant position for some of these other bacteria that aren't so friendly to come into and fill that void. Like, how do you guys think about that?
Yeah, I mean, again, we have to weigh the risk and benefits of the treatment that's required for the patient versus the side effects that the medication can cause.
Mm-hmm.
One of those side effects could be C. diff. In general, there are certain antibiotics that might be a little bit more likely to cause C. diff. We try to minimize the use of those antibiotics. Sometimes we can do that, sometimes we can't. Again, the priority is always to find the best or the most effective drug for the bug that you're treating.
Right.
But if we have multiple options to do that, then we always try to pick the medication that is less likely to produce a side effect.
Well, so now here's a question though. So with C. diff, right? And actually, real quick, can you tell people how C. diff manifests? What does it do?
Oh, yeah. So it causes profuse watery diarrhea, crampy abdominal pain, bloating. And if it gets more severe, it can cause a lot more severe symptoms.
Explosive diarrhea.
Yeah.
Right?
You can go into actually shock and things.
Wait, really?
Yeah.
I did not know that.
So if it progresses, because C. difficile produces its own toxin, which causes diarrhea, that can cause something called megacolon, which can cause a rupture of the gut in severe cases. Again, so that is again not a common side effect of C. difficile, but something that can
occur.
The most common symptom though is that profuse watery diarrhea.
Yeah, so that's the most common manifestation that I've had to deal with. You gown up, you gown up, you put your mask on. I had to put a mask where so I put my own mask on, and then I had to put my toothpaste and the second mask. And then wore that.
Yeah.
So it smelled. It smelled.
Yep.
So, but yeah, it wasn't pretty, and I can only imagine how that patient was feeling too. But but we're going back to what I was going to tell you. What I was going to ask though is, so C. diff. Well, actually, hold on. Is C. diff a more antibiotic resistant bacteria, or is it just because it can make that that spore form, like it just evades a lot of the immune system?
Yeah, it can basically, that spore, the ability for it to form that spore allows it to kind of hide out when times are bad for it, and so it can avoid detection and destruction by certain antibiotics.
Okay,
but there are antibiotics that can treat the C. diff also, which is the ironic part. Antibiotics can trigger C. diff infection, but the treatment for C. diff is a different type of antibiotic.
Because my question to you is, okay, if you have a bacteria that is resistant to a lot of antibiotics, and so that actually maybe cuts your options short.
Yeah.
Like, what do you do?
To reduce the risk of C. diff?
To reduce the risk of C. diff, or to to reduce the risk of C. diff, or you have an antibiotic that it's the only thing that can treat this bug.
Yeah.
But maybe it's the side effects are really severe or something like that were to happen.
Yeah, I mean, if we have limited options, we do the best we can with the situation we're dealt with, right? So we keep a close eye for side effects, including C. difficile by monitoring for diarrhea. We monitor blood work to make sure that there's no unseen issues that that are occurring as a result of the antibiotic that we can't see with our own eyes. And it's a combination of close monitoring with exams and keeping an eye on these things we just mentioned, blood work and symptoms and things like that.
Absolutely. Wow.
Yeah.
You have a very specialized area of research, and you mentioned it earlier. So it's the prosthetic joint infections. So as we age, sometimes we'll get patients who have, I think, arthritis or osteoarthritis. They're in need of a hip replacement or like a knee replacement.
Sure.
But that's actually not something I ever considered, that these infections can happen even in spite of us trying to preserve somebody's functionality of their body.
Yeah.
I was shocked to read that the mortality rate of some of these prosthetic joint infections is very high. I actually have a specific statistic from you sent me a couple of papers before this episode, and I was shocked. So I wanted to quote this correctly. So it said, the one paper I read said that specifically the 3-year mortality rate of prosthetic joint infections are comparable to the 5-year mortality rates of breast and prostate cancers.
Certain ones, yeah.
Certain ones, right? Dr. Shah, why are these specific infections so deadly?
Yeah, it's for multiple reasons. So number one, these prosthetic joint infections, they involve metal. And like I mentioned before, when you get infection on a piece of metal, there's this ability to form something called a biofilm. That biofilm creates layers of bacteria on the surface of the metal where the immune system can't get to it as easily. And that is very difficult to eradicate. If you have multiple layers of bacteria, right?
Okay.
And you give someone antibiotics, you can eliminate the first 10 layers, but the bottom 30 layers survive, and they've been exposed to low amounts of that antibiotic, and now they can become resistant. So that's one issue with the challenges associated with this.
Okay.
The other thing is the going back to what we were talking about before, but the patient themselves. People who require artificial joints tend to be older. They tend to have more comorbid conditions.
Mm-hmm.
And so those things can influence or affect or compound the problem more. So if you already have bad arthritis and you're elderly, and then you get an infection on top of that, that can tip a lot of people over the edge. The other thing is that when you get these types of infections, the treatment is it's not just antibiotics. It's usually a combination of surgery and antibiotics.
Okay.
And sometimes those surgeries require prolonged immobility, prolonged hospitalization. And then these things, like we just mentioned before, they can create complications and increase the risk of mortality on their own. And so all these factors can play a role as to why the outcomes can be potentially so bad.
Yeah, let's dive into some of those, so you have a patient that's coming in for an arthroplasty.
Yeah.
Which is the medical term for a
artificial joint.
Artificial joint, right?
Yeah.
What goes through from an infectious disease context? What's going through your guys' head of, okay, this person's coming in for an arthroplasty. How do we anticipate and prevent a PJI from occurring?
Yeah.
Let's start there.
Usually it's done through the orthopedic surgeons, but I can tell you the basics. But
yeah.
So they do a couple of things. So one, they want to optimize your nutrition status. So you'll hear the surgeons say you need to if they'll check some blood work to look for something called albumin, a level like an albumin level. If that's low, they recommend usually supplementing your diet with protein. And the reason for that is albumin and other types of proteins are very important in the healing process. So when they do a surgery, one of the risk factors for infection is poor wound healing. Remember, your skin is your natural barrier to the outside environment. If it cannot heal in a timely manner, the longer it remains compromised and open, that's the longer the opportunity for something to get into the body remains.
Mm-hmm.
And so optimizing your healing is an important step in reducing the risk of infection.
Okay.
The other thing that they often do is they screen patients for certain types of infections. Usually the most common one is something called MRSA.
MRSA?
Yeah.
That's
It's methicillin-resistant Staph aureus.
So can you explain? So that's an antibiotic, but it's resistant. But can you explain kind of like why? Like I know from prior knowledge why, but can you explain like what's so severe about that specific staph variant?
Yeah, I mean it's Staph aureus tends to be an aggressive bacteria in general. MRSA produces some additional virulence factors, which can cause a more severe type of infection.
Okay.
And on top of that, it's a little bit more difficult to treat than standard staph infections. So you can't use your standard, what we call beta-lactam antibiotics to treat MRSA.
Okay.
And so what surgeons often do is they will screen you by putting a Q-tip in your nose and swabbing your nose, because that's where MRSA can tend to colonize. And if you're noted to have MRSA colonization, they can attempt to decolonize you with a combination of medication and actual type of soap that's available over the counter, something called HIPAA-Cleanse.
HIPAA-Cleanse. Okay.
And so that's something that's done. That's an additional measure that's done to reduce your risk of infection before any type of surgery.
Yeah, because the reason why I asked about it, because we have MRSA patients on our floor.
Yeah,
we come pretty often actually, and it's something that they, we try to be wary of with in regards to their antibiotic resistance, because if it's such a resistant bug, I've heard it can get to a point where it's like a flesh-eating bacteria. Like it's something that we got to
in
careful.
rare cases, it can do stuff.
Yeah. But then revolving back to the PJI. Okay, so they do actually. That was going to be one of my questions for you. Is there like ever a regimen that they do before they have the surgery to get their body in a state that it's more resilient to a PJI?
Yeah, I mean, like I said, I think it's a combination of screening for MRSA and addressing that as best as possible through decolonization if you're positive for that.
Okay.
Optimizing your nutritional status, specifically your protein. And the other thing is weight loss. So a lot of surgeons won't perform surgery if individuals are over a certain BMI. And that's because there's higher risk of complications for people who are above a certain BMI, not just from the surgery, but from anesthesia as well. An intubation standpoint. And then also, remember, when these people get these surgeries, they're going to be immobile for a long period of time. You get an artificial knee. It's not like you just sit up and
you start walking around again.
Yeah. Right. So if you're already in a deconditioned state and then you decondition it further.
Right. It goes back to those intangibles that we talked about. It's like laying around for the long period of time and you can't move.
Yeah.
The increased chances of those pressure injuries occurring.
Yeah.
I also think there's actually something another thought I had was that the fact that, I mean, hospitals themselves can be pretty isolating. So maybe there's some psychological that can also occur. And I think more and more I'm seeing that it's a two-way street between your mind and body. Sometimes psychological conditions can manifest have physiological manifestations, so that can play a part, I'm sure.
Yeah, that's a known phenomenon.
Yeah, but okay, so essentially what you're telling me is there's a weight limit, as a sense, a BMI limit at the very least. Okay, they have the surgery, and let's say a PJI forms.
Sure.
So, first question I have is, what types of bacteria usually are the culprits behind a PJI?
Yeah. So, I mean, first, the risk of getting a prosthetic joint infection is not high. So, I want people to know this is not something that's like a 50% risk or something.
It's low. It's
about 1 to 2%.
Okay, but when it does happen, it's serious.
Yes, when it happens, we tend to treat that much more seriously. So, the most common organisms are staph bacteria. Staph aureus tends to be the most common single organism that causes prosthetic joint infections. And so that's the one we suspect up front without any culture data. And that's the one we want to cover empirically before we get culture data to confirm a diagnosis when we're worried about PJI.
Okay. Biofilm. So you talked about like how the bacteria can create, it sounds like almost like it's like a shield of themselves around this metal.
Yeah.
Is that like a pretty common phenomenon? Is that like just like a hallmark of these PJIs? Like you always are going to get this biofilm?
If it's an acute PJI, so if it happens within the first 90 days or so, usually there's not enough time for biofilm to form in any substantial manner.
Okay.
But after that 90-day period, usually there's a higher risk of biofilm settling in onto the metal. Okay. So when we classify prosthetic joint infections, we have early and late.
Okay.
And so that's distinguished by that 90-day mark usually.
So if you treat the top layer with an antibiotic, but then what happens is you run the risk of the bottom layer becoming antibiotic resistant.
Yeah.
What do you do then?
Right. So that's the challenge. So when you have 10 layers of bacteria and you give an antibiotic, it can eliminate the first 3 layers, but then layers 4 to 10 see just enough antibiotic to get resistant but not die off.
Mm-hmm.
And so this is the challenge. We the most definitive thing to do is remove that biofilm, but there's no nuanced way to do that. The way would be to remove the metal that's involved. So often what they do is when there's a prosthetic joint infection that develops, one of the standards is, or one of the standard options is to remove the metal, put what's called an antibiotic spacer between the two bones that make up the joint, and then treat the individual with antibiotics. And then only after the infection has been adequately treated and the patient has proven themselves to not be actively infected, they'll put back new metal.
New metal, but doesn't that run the risk of another one?
It does, unfortunately, yes. But again, basically you can't. You could have just a spacer in there, in theory, but that limits the mobility of the patient, and the trade-off would be you may not be able to do a lot of activity. So, before we put back new metal, before the surgeons put back new metal,
mm-hmm.
there are multiple things that are done to minimize the risk of any reinfection. So that includes, like I just mentioned before, there's an observation period after you treat these patients to make sure that there's no active infection. And during that observation period, your surgeon could do blood work looking at inflammatory markers. They'll do a clinical assessment periodically off antibiotics to make sure there's no signs of inflammation or infection that are present that would suggest ongoing infection. And they can even culture the joint space.
Oh, like they'll get a swab and kind of.
They'll take what's called an aspiration of the joint. They take a needle and take the fluid.
Okay.
Joint space.
Like a swab, they can't get in there with a swab. So like a needle, they're gonna
Yeah. And so they can use these things to more definitively establish, you have no infection left from the prior episode.
Okay.
So, and again, the antibiotic spacers that they put in, more and more commonly now, those spacers contain antibiotics, which can also reduce the risk of localized infection from developing as your body is healing.
What does that spacer look like? Is it just like a block of antibiotics?
Yeah, it's a block of cement.
Of cement?
Yeah.
Really?
So it's a cement spacer.
Okay.
Usually. And it's porous, and it contains antibiotics as a part of that cement component.
Oh, okay.
And so it's put between, so all your joints by definition connect two bones together.
Mm-hmm.
So the spacer, when the joint is removed, the spacer is put between the two bones that make up that joint, and that spacer prevents the bones from fusing together abnormally. Because that's what would happen if you didn't have anything. If you didn't have a joint, basically.
Okay.
The bones would eventually, over time, fuse together. The joint creates that lubrication and that space, which allows you to move, your knee, your hip, whatever.
Right.
But if that's no longer there and you just have two bones that are touching each other, they, in theory, will fuse together over time, and you could create serious problems that way. So the spacer is used to prevent that from happening. It spaces the bones apart and prevents that fusion process from occurring.
So this is an interesting question. When you have the infection, is it coming from like the joint onto the metal, or is it kind of like colonizing like the metal? Like, you understand what I'm saying? It's like the direction of the infection. Does that ever matter?
So the direction of the infection can occur from multiple ways, in multiple ways. These infections are acquired by different mechanisms. So again, when you do surgery on someone, including patients with prosthetic joint infection, anyone, right? You have to cut the skin. There's no way around that, right? Once you cut the skin, there's always a risk of something from the outside environment from getting into that space. So one mechanism of infection is, as the wound is healing from your prosthetic joint surgery, something gets introduced. And again, we're dealing with very microscopic bacteria. You're not going to be able to prevent every single organism from potentially entering into that space. So it becomes tough. The surgeons, the doctors, we do everything we can to minimize that risk. We usually put something called betadine or an antiseptic solution around that area.
We've used that on the floor as well.
Yep.
I've seen that. Yeah.
They try to cover the wounds. They do all sorts of things to minimize that risk, but nothing is 100% full.
Of course.
So one mechanism is through introduction of bacteria from the outside environment. Another mechanism is, and this happens unfortunately, where you get an artificial hip, right? And you're in the process of recovering. You go to physical therapy, and then you slip, fall, and you injure yourself. Now you create an area of trauma around that area.
Inflammation, right? So your body's going to shuttle that. And so...
Exactly.
Okay.
So you get an inflammatory state, you get damaged tissue, and then the combination of those things can introduce infection as well.
Is it because it creates an environment that's like in that site that now infection's more likely to come up?
Yeah. It basically creates an environment where you're at higher risk of getting bacteria introduced into that site of into that surgical site, basically.
So it all feeds into each other, like kind of the discussion we were having. Okay.
Yeah.
When I was reading the papers, they mentioned that there were a couple of techniques to try to get rid of these infections. The antibiotic spacer was not one that I saw, but the one I saw was called debridement.
Yeah.
Can you explain what debridement is?
Yeah. So debridement or debridement is it's just cleaning out the infected tissue. So what usually happens is when someone gets an infection in their prosthetic joint space, there's a couple of options. Again, one of the standards is to remove the metal. Sometimes they can't always do that. If there's high risk for morbidity or mortality from removing the metal, they may not do that. But all the patients need to get the infected tissue cleaned out and removed. And that's what debridement or debridement is.
Okay.
You're basically cleaning out that infected tissue, getting rid of the bacterial burden that's present at the site of infection as best as you can. Once that's done, if the metal is able to be removed, that's after the debridement is done, you put the spacer in. And so the spacer is part of a larger surgery that's done, which involves debridement and what we call irrigation, so washing out the infected tissue.
From what I understand, debridement has its own drawbacks. Like you can even make the actual area of the wound bigger in a sense, because if you're kind of cleaning it out, I don't know. Like,
So,
can you expand on that?
I wouldn't call it a drawback, but I mean, so what you're basically trying to do with the debridement procedure is get rid of all the infected tissue.
Okay.
So you don't know how much infected tissue is present
Until
you open it up.
Oh,
and so
okay.
what might have been initially a very small area, you unfortunately find out, whoa, that infection is going all the way down. Like it's starting from the hip, but it's working its way down towards the femur or something.
Okay, and there's no way to screen that, is there?
Not easily. I mean, imaging can sometimes help, but the gold standard is you got to open these people up in the OR and see what you're actually dealing.
Which again comes with its risk. If you open somebody up, you risk them another infection too. So okay.
Again, in this scenario, once a patient is infected, the surgery part is an important component in dealing with the infection. Giving antibiotics alone is usually not effective in dealing with these types of infections because of that metal and that biofilm. And surgery alone obviously would not be effective because if there's any lingering bacteria, you need antibiotics to clean
it out. So it's a two-step solution. Two-pronged approach.
Yeah.
Another actually this was a paper you were co-authored on.
Sure.
So I was reading, it was called, again, let me be specific with this because it was Pseudomonas Prosthetic Joint Infections, a review of 102 episodes.
Sure.
So it was focused on the clinical outcomes of patients with infections with following their hip or knee replacements.
Yeah.
First question, can you explain what Pseudomonas is?
Yeah.
And then second is, why was this specific PJI a difficult one to treat?
Sure. So Pseudomonas is a bacteria. It's specifically something called a gram-negative bacteria, gram-negative bacillus or rod.
Okay.
That just describes how it stains and the shape.
In the shape of it.
What makes Pseudomonas particularly challenging in terms of like from an infection standpoint is it tends to be resistant to multiple classes of antibiotics.
Okay.
And so there's certain antibiotics that you inherently can't use for Pseudomonas. And that's specifically for Pseudomonas aeruginosa, which is a subspecies of Pseudomonas.
Aeruginosa.
Yeah.
No, like oregano.
No, not it's not. It's with an A, not an O.
Okay.
But yes. And so this bacteria becomes very challenging for infectious disease doctors to treat because it's already resistant to certain classes of antibiotics, and it has the potential to become resistant to other classes more easily, just because of the mutations that are available to it specifically. It creates these, or it can develop these mutations more readily. And then again, when you have patients who develop these infections in their joint space, if the metal is kept in place, right?
Mm-hmm.
Pseudomonas has a much stronger ability to form these biofilms than other bacteria,
Right.
or certain other bacteria. And so it tends to be more aggressive in forming that biofilm. It already tends to be more resistant in nature. And the combination of those two things can make it very difficult to control the infection without removing the metal and giving the proper antibiotics.
Okay.
And so those are the challenges associated with this bacteria.
Yeah, so there was something I read was that so the paper said that there was a 5-year survival free from failure was significantly lower for diabetic. So basically, like, it sounded like, if I'm understanding this correctly, diabetic patients who were diabetic had a lower survival rate from these PJIs than patients who didn't.
Yeah, I think from the study, I think it was survival meant in this case. I think the difference between treatment success and failure.
Treatment success, I think, is what it was instead of survival.
Yeah. And so, yeah, I mean, what we saw that is if they had diabetes along with this infection, they had a higher incidence of failure.
Right.
Failure meaning that despite whatever interventions were provided, they continued to grow the organism within their joint space, and they may have required to repeat surgery, repeat antibiotics, or usually a combination of both.
Well, this raises an interesting question. So we talked about how patients go through a screening in maybe like a period of time where the surgeon is like, listen, you need to dial in these certain things before we can operate because we need to reduce the chances that a PGI can form. With a diabetic patient, would you even say that there needs to be a period where they can have to get their metabolic state in a condition? Maybe you're not going to necessarily eradicate the diabetes.
Sure.
But you get the diabetes to a point where, okay, it's controlled enough or it's not as severe enough that we can now operate on you and get this.
Absolutely. I mean, optimizing people's chronic medical conditions is an important step in reducing the complication of surgical procedures, including the placement of prosthetic joints and everything else. So optimizing your blood sugars, there's something called a hemoglobin A1C that surgeons and medical doctors who are clearing patients for surgeries often look for to make sure it's not above a certain threshold, because that, again, increases the risk for poor wound healing, infection, and things like that.
What is that number for your hemoglobin A1C that you're considered diabetic?
What's the number for defining diabetes, or you're saying it's the number that the surgeons look for?
Let's actually ask both. So what's the number that if you have a hemoglobin A1C of this number, you are considered by a doctor diabetic, and
I
then
believe it's 6.5 is the number.
Okay,
we need 2 separate readings to confirm that.
Okay,
the cutoff for what is a acceptable A1C for surgery tends to have some variability. I am not a surgeon, so I'm not sure exactly what they're looking for.
Right.
But generally from an infectious disease standpoint, we worry when it's usually over 9, 10, so double-digit A1Cs. Would be very high risk for complications from the diabetes from an infection standpoint. So, but what the surgeons look for, you would have to ask them. There might be variability in that. I'm not sure.
Gotcha. Okay, cool. So when we initially, I did some research of you in preparation for this podcast. When I saw that this was a niche area, I didn't even realize, I didn't stop to think that your prosthetics can get infected. This actually hits hits close to home for me because my grandmother's diabetic, and she's had two knee surgeries.
Okay.
Thankfully, there were no complications, but I can only imagine how many people this touches.
Yeah.
How prevalent are these PJIs? I know you said they're rare, but there's clearly it's a sizable amount if this is a documented issue.
Yeah, I think what's happening more and more is that a higher number of people. So we live in a country where the population is aging, obviously.
Mm-hmm.
And unfortunately, we have a country where there's an increasing number of patients who are gaining weight and becoming more obese. Obesity can strain your joints, which can increase the incidence of you requiring an artificial joint. So that elderly population that's expanding, and then combined with a population that tends to have a higher and higher BMI over time, is increasing the total number of these artificial hips, knees being placed year over year. And again, as you increase that number, even though the percentage is 1 to 2% of a risk, the higher the absolute number, it increases the absolute amount of the infections that we see. And so that's what's happening. That's what you're seeing. It's becoming more prevalent because more and more people are requiring these procedures in the first place.
Yeah, which leads back to the earlier part of our conversation where we were talking about like what are the things we can do to save, like to prevent, avoid infectious diseases, which does again almost always includes those 3-4 pillars of the diet, sleep, exercise, and the stress management.
Yeah.
But like even like because exercise can help with like the bone density. I know.
Yeah,
So
it
like
can.
if you're doing your exercise into your 50s, 60s, like your quality of life is going to be better from the standpoint of like you don't have to get this. Ideally, you don't have to get this hip replacement, the knee replacement, because that comes with its own complications.
Yeah.
Do you know of any new advancements in the field of prosthetics that have found ways to mitigate the development of PJIs? Like, is there some kind of prosthetic material that can reduce the likelihood of infections or something like that?
Yeah, and that's an area of ongoing research, and so there's a huge variety of these things. So there are new compounds that are being developed that are anti-biofilm in nature, or are what you call it, like they are more likely to prevent bacteria from sticking onto the surface. They're using UV light technology to actually prevent bacteria from growing on the surface.
Would that be like a new surgical technique? Like you open them up and then you do like a UV light, or
I think it's actually the prosthesis itself that contains a low amount of UV light that's emitted or something like that.
Really?
The specifics
Oh,
of
so it sits inside you and it emits UV light.
Yeah, and that can reduce the risk of any bacteria from sticking on to the metal. Basically.
That's really cool.
Yeah. There's different surgical techniques that are being used. I can't comment on that as specifically as I'm not a surgeon, but
of course.
But they're using that to reduce the risk of infection. Generally, the less incisions that you make on an individual, lower the risk of infection. That seems intuitive. And so minimally invasive procedures are being incorporated into these into the prosthetic joint surgeries. And that could be another mechanism by which you can reduce the risk of infection down the road. Yeah, I mean, there's things that are being worked on for sure.
Anything you and your, I don't know if you have a lab or anything that you guys are working on these. Anything you guys are specifically working on?
I don't have my own lab, but I work with one of the orthopedic surgeons who does have his own lab, and his big area of research is biofilm.
Okay.
And so they're working on understanding the nature of biofilm more, and I work with them on that aspect as well. There's also, in terms of novel treatments for infection, there's even something called phage therapy, which is going to sound weird, but it's actually using a virus to target bacteria.
Oh, okay.
And so it's not a preventative measure, but it's usually something that's used as a last line of treatment. When there's no good antibiotic options and the patient is deemed too risky for any further surgery, we have had certain patients that have been enrolled in trials that are involving phage therapy.
Using a virus to kill the bacteria.
Yeah, so you can actually design a virus that specifically targets a bacteria that you're trying to eradicate from the body. And it will only target that bacteria, which is really cool.
Yeah.
Again, this is not yet standard.
Yeah, this is standard care.
This is more
research experimental.
Research side of things.
Okay.
But we are incorporating this for certain patients if they fulfill certain criteria, usually as last line therapy, to see if that can help eliminate the infection entirely, or at least lower the burden of the bacteria so that the person can have a decent quality of life.
That's fascinating because going back to my CAR T research, there was the standard way of creating CAR T is a lentivirus model. So you would use a virus to inject, introduce the DNA or the RNA or whatever the instructions for your T cell to make the CAR T, like the signal, the antenna. I had a whole blog post on this. If anyone, I'll link it in the description for people who want to read. But but that of course can come with its own drawbacks and stuff. But I never thought you could actually I didn't put two and two together. You could actually use the virus because I know a phage is a virus specifically that targets bacteria.
Yep. It's a bacteriophage.
Bacteriophage.
It's a virus that targets bacteria.
Yeah, but I never thought like we could actually use that as a treatment like that. I just for whatever reason didn't put two and two together.
Yeah,
that's fascinating.
Yeah. It's something that's developing traction now. So it could be something that we incorporate more standardly in the future. But Right now, the studies are being
Of course.
undertaken to see how effective it is, how to dose it, how often we should give it,
Yeah.
and most importantly, what the efficacy is long term. And
Of
that's
course.
what we're looking at.
Of course. Wow, we really flew by these questions. So kind of just wanted to like kind of close up everything. So, actually, real quick though, on the prosthetic note, just more of a philosophical question, I guess, for you. So when we're talking in like prostheses, these prostheses have like a shelf life in a sense, right? Like how effective they can be. And then do you consider prostheses is that actual longevity for a patient, or, especially because of the idea that these prostheses can get infected?
So again, the infection risk is low. So
Okay.
the overwhelming, like 98, 99% of patients have no infectious complications from their prosthesis.
Mhm.
So even though the infection risk is there, I want, to emphasize it's not a high risk.
Right.
So for the majority of people, they never have an infectious complication from their prosthesis.
Of course.
The type of prostheses that are being made are more and more durable, more and more flexible. They're using newer material, newer metals. The technology from that end is getting better as well. And so these things tend to have good longevity. The majority of these people that get these artificial joints are already elderly. So there's a very good chance that they get to keep those joints for the rest of their life. And the joint provides, immense flexibility, immense movement. It can improve their quality of life. It can improve their day-to-day activity. And so it can actually get rid of a negative cycle that a lot of patients go through. So if you can imagine, if you have a bad knee or a bad hip, right, it's going to limit your activity. You limit your activity, you start becoming deconditioned, you start gaining weight, you become unhealthy.
Right.
It adds more burden to the joint, and you keep going through that cycle. It becomes more painful, you're less active, and you can break that cycle through the introduction of that artificial joint. Because now you're like, you know what, it doesn't hurt as much anymore. So you're staying more active. You stay more active, you lose weight, you become more conditioned.
You can go to the gym again, right? Right.
And those things are important for anyone's health in general, but it also reduces the risk of complications for infection, for a lot of things.
Right.
So it breaks that negative cycle that people often get into when they get arthritis or they get damaged joints from whatever it is, chronic medical issues and obesity and things like that.
Yeah, and maybe in one day we'll get to the point where if someone has osteoarthritis, like there's some kind of treatment where we can repair the connective tissue between the bones. But
Maybe.
until then, maybe. But like until then, like these prostheses that we have, like these replacements, they're like our best. Would you say they are our best option at the moment? And the technology for them is getting better every day.
Yeah, I think it's the most established way to address a chronically damaged or devitalized joint right now. And the technology is definitely getting better day to day. The surgical techniques are getting better. The precautions are getting better. And so the risk is going to hopefully keep going down. It's already low to begin with, but if we can get it down to less than 1%, fantastic. We'll see.
Heck yeah.
Yeah.
Dr. Shah, so if you had to give, a closing line or just something you would always tell someone about, like to keep in mind about infectious disease as it relates to like longevity, getting older, like kind of what would you say to the people who are watching?
Yeah, I mean, I think in general, infection prevention is a multifaceted thing. It's not just doing one thing versus another. But I think the things we talked about today, the adequate nutrition, the adequate, staying active, getting enough sleep, vaccinating, being cognizant of what is high risk and what's not, and avoiding the high risk things that could increase the risk of infection are all important things to take into account.
Yeah. And then also understanding, like maybe once you have that infection, there are like things like understanding what happens to your body, like when you get these infections, like why the fact that as we get older, because like I don't think I was ever really explained to me until maybe I got into college or maybe having conversations like this with you about like, your immune system just gets older. Well, hold on, why? And is there anything we can do to slow that aging process of that immune system?
Sure.
So yeah.
I mean, again, these are God forbid you ever get an infection. It's always important to communicate with your doctor.
Of course.
Ask these questions, and that way there's an understanding between the patient and the doctor, and that's obviously an important part of the whole healing process.
Yeah.
So.
Ideally, I mean, I love getting coffee with you and having these conversations. I would not want to see you in that context because that means something's going.
Most people wouldn't want to see me.
Yeah, you're just thinking on your clipboard. It's like Hrithik. It's like Hrithik. What happened? Staph infection from a jiu-jitsu mat. What can I say? I've had a staph infection or once before, but
okay.
Yeah, that's what I say. Like they're gross. They're terrible.
Yeah.
But yeah, everybody. Listen, it's not pretty. Like infectious disease, it's definitely not for the faint of heart, but would you say like as long as you understand what you can do for the prevention side, and then you lay that appropriate groundwork before they happen, it's going to decrease the likelihood of getting these infections, and if you arm yourself with the knowledge of what to do once you have that infection and working together with your physician, those outcomes are going to be much better.
Yeah. Agree 100%.
Awesome.
Yeah.
Was there anything that we talked about that we didn't talk about today that you think we could have covered?
I think we covered. Yeah. Ryan, I think we covered everything.
Sounds good.
To cover. Yeah.
Yeah. Well, I think we'll have to have you maybe back on at some point. Like, let's say, like when they come out with a new prosthesis. Maybe I don't know. Maybe it shoots missiles out to the bacteria or something like that. And it'd be like Hrithik, like this is new prosthesis came out. I'm like, yo, let's get on another episode and talk about it. But. No, Dr. Shah, if people want to, contact you or book an appointment or anything, like, this actually might be a good question. Like, as a specialist, actually, can people come straight to you? Do they get referred to you?
Usually, infectious diseases, we get it's a referral base.
Okay.
So usually it's done through your family doctor, or if you're hospitalized and you're seen by an infectious disease doctor within our practice, then you get to be seen by our group.
I gotcha. Okay.
But, so that would, just talk with your family doctor if you feel or they feel that you need to see an infectious disease physician. We could be an option. We'd be happy to see people in our clinic. So
fantastic. Well, thank you so much for coming on. This was an awesome episode. So much really to learn about infectious disease. I figured this was gonna be like a nuanced topic, but
yeah,
it's definitely definitely underestimated like how much we could actually dive into. So this is fantastic. Thank you so much.
Yeah.
And to everybody watching, thank you guys so much for tuning in. And I'll see you guys on the next episode. Take care. Bye.